Hello everyone. In this session, we are going to discuss a very important topic, that is thyroid neoplasm. So in your university exam, you usually get a long question on either papillary carcinoma of thyroid or follicular carcinoma of thyroid or medullary carcinoma of thyroid. So we will be discussing 4 thyroid tumors here: papillary, follicular, medullary and anaplastic. All about them we will be discussing. But on anaplastic, you usually don't get a long question, but on other 3, most commonly on papillary carcinoma, you get long question in university exams. It's a very important topic. So let's start it. So here you can see we are starting the topic, that is thyroid neoplasm. So here we will be discussing first of all the classification of thyroid neoplasm. Then I will let you know the 4 types, that is papillary carcinoma of thyroid, follicular carcinoma of thyroid, medullary carcinoma of thyroid and anaplastic carcinoma of thyroid under a fixed set of heading. For each of them, I will let you know the introduction, cell of origin, age, male-female ratio, risk factors, genetic alteration, the mutations, gross, most importantly microscopy of each of them, spread and prognosis. So if any one of them is coming in your exam, you have to write that one only. So usually question comes on the papillary and also on medullary, but really the question can come on follicular and anaplastic also. So we will be covering all 4. Rather, we will make a comparative table in the end to compare all 4. You will have a better retention. So let's start it. So I am teaching you the topic thyroid neoplasm. So we know we have a gland, the thyroid gland, which is present in the neck over the trachea. You can see it here. It is having 2 lobes, the right lobe, the left lobe. They are connected with isthmus. Now thyroid neoplasm can occur on any of the lobe, and it will grow and it can compress the surrounding structures also. So that is thyroid neoplasm. So the classification wise, there are 4 tumors we will study in detail. First, I will let you know the papillary carcinoma, then I will let you know the follicular carcinoma, then medullary carcinoma, and finally the anaplastic carcinoma of thyroid. I request all my dear students to take out their notebooks, to take out their pen and make this comparative table with me only while watching the lecture, so that you will not give any extra time. During the lecture only you can make this table, so that it will fit in your memory permanently. If you have already have the book, the hard copy of our book, so this table is given to you in the book as a workbook. So just take out your book and start filling this table with me. So can we start? So let's start with papillary carcinoma of thyroid. So we will be discussing them under the fixed set of heading, that is introduction, cell of origin, age, female-male ratio, risk factors, genetic alteration, gross, microscopy, spread and prognosis. Now we will see a little bit about the anatomy of the thyroid and then we will start it. So you know thyroid is a gland, as I told you, which is present in the neck over the trachea with 2 lobes. You can see the right lobe, you can see the left lobe, and you can well see the connection between them, that is known as isthmus. This is thyroid gland. Tumor can occur anywhere on the thyroid. Here you can see the borders of the right and the left lobe with the isthmus in it. Here you can see it well. And inside the thyroid, what type of cells are present? Now in the thyroid gland, you can see this is the thyroid gland. If you see the histology of the thyroid gland, you can see there are 2 types of cells. The cells in the thyroid gland are arranged in the form of the follicles. Can you see? These are the follicles. Cells lining the follicles are known as follicular cell. So these are the follicles, and the cells lining the follicles are known as follicular cells. And the background is the stroma. In the stroma, interspersed are the cells. Can you see these cells? Stromal cells. These are parafollicular cells. So we have follicular cells and parafollicular cells. Follicular cells are the cells which line the follicle, and parafollicular cells are present in the stroma. What does this secrete? Follicular cells secrete T3 and T4, and parafollicular cells secrete calcitonin. So now I'm going to discuss the 4 types of thyroid tumor. So out of them, 3 of them arise from the follicular cell: the papillary carcinoma, the follicular carcinoma, and anaplastic carcinoma. These 3 arises from the follicular cells. So that's why whenever there is a tumor, either papillary carcinoma, follicular carcinoma or anaplastic carcinoma, patient have hyperthyroidism because excess of T3, T4 will be secreted in the blood. But the medullary carcinoma arises from parafollicular cell. So medullary carcinoma, since it is arising from parafollicular cell, whenever the female have or any person have medullary carcinoma of thyroid, so excess of calcitonin is secreted in the blood. So that will be the main thing here you have to understand. Now let's start the first tumor. We will be discussing 4 one by one. Let's start the first one, that is papillary carcinoma of thyroid. So can you see here we are going to discuss the papillary carcinoma of thyroid. It can occur anywhere on the thyroid. It is in the introduction you have to write this is the most common type. 75% out of the total thyroid tumor is papillary only. This is the most common type among the four. Most common type. Cell of origin, I told you it is follicular. So 3 of them arises from follicular cells. The papillary carcinoma, follicular carcinoma, and anaplastic carcinoma. So it is arising from the follicular cell. It occurs in young female 20 to 40 years of age. Female to male ratio 3:1. So if you can learn the ratio, it's good. You have to learn it is more common in female than male. So 3 times it is more common in female as compared to male. That is the meaning. So female to male ratio is 3:1. Risk factor, the most important risk factor is radiation exposure to the neck, head and neck. So if there is a radiation exposure to the neck during childhood, there is increased chances of developing papillary carcinoma of thyroid in future. So the neck radiation can be to treat the lymphomas. For example, someone is having lymphoma. So to treat the lymphoma, the radiation exposure to the neck has to be given. Or there is some other malignancy. To treat that, radiotherapy has to be given. So the thyroid is exposing to radiation. Or in some atomic bomb explosion, right? Hiroshima, Nagasaki explosion or radioactive explosion. So the thyroid get exposed to the radiation. That can be the risk factor. That can be the risk factor. Genetic alteration, learn the name of the gene. So most commonly it is the red gene which is mutated or anti-RK gene rearrangement. Learn the name of the 2 genes. What 2 genes? Red and anti-RK. That is the mutation which leads to papillary carcinoma. So we have seen the introduction, the cell of origin, the age, female-male ratio, risk factor, and mutations till now. Now coming on the gross and microscopy. Have a look on the gross. How does the tumor look like? Can you see? This is the tumor. Can you see the boundaries of the tumor? Where is the tumor? Make out the boundaries. So this is the boundary. It is a well encapsulated tumor. It is well circumscribed. It is encapsulated, inside which a gray white firm hard mass is present. Gray white firm hard mass. And if you are cutting it, you can see in this mass, in the tumor, if you can see this image nicely, you can see the papillary projections are there. The papillary projections are there. So papillary projections are there and areas of calcifications are very common. So this is the gross. So in the gross, you have to write the tumor is encapsulated. It is well circumscribed, a grayish white mass is there, and it is having the papillary projections. Grossly also small papillary projections are seen. So that's why it is known as papillary carcinoma, because finger-like projections are seen here. That is gross. Now microscopy is ultra important. Sometimes you don't get a long question on papillary carcinoma of thyroid. You get a short question only on the microscopy. So you have to write the microscopy only separately. So please, whenever we discuss the microscopy of any of the thyroid tumor, first of all, you have to tell me the pattern of arrangement in which the tumor cells are arranged. So pattern of arrangement of tumor cells, the pattern of arrangement of tumor cells. So look at the image and tell me how the tumor cells are arranged. Very peculiar. The tumor cells are arranged in finger-like projections. Can you see the diagram? They are looking like finger-like projections, the papillary pattern. So the tumor cells are arranged in the form of the papillae. Papillae means finger-like projections. So I will draw a few papillae for you. So let me draw the papillae for you. So tumor cells are arranged like this. Okay. The tumor cells are arranged like this. So this is the arrangement. Where are the tumor cells? Let me draw. So these are the tumor cells. The tumor cells are arranged like finger-like projections, which are known as papillae. So I will draw the papillae on which I will try to draw the tumor cells. I am drawing the tumor cells here. So all over there, I will draw the tumor cells like this. Okay, the first thing. Now these papillae, can you see these finger-like projections which are known as papillae? The core of these finger-like projections is made up of the blood vessels and the fibrosis. These are the blood vessels, blood capillaries and the fibrosis. It is known as fibrovascular core. What it is known as? These are the blood vessels along with a little bit of fibrosis is there. So in the core, you have the blood vessels and the fibrosis. So blood vessels and fibrosis is present in the core. It is known as fibrovascular core. So these are papillae. The tumor cells aligned on the papillae, and the core of the papillae is formed by fibrovascular core. So there is a fibrovascular core. So that is the arrangement. So we have discussed the arrangement. The tumor cells are arranged in papillae with a fibrovascular core. The arrangement is over. Now describe one tumor cell. Take any of the tumor cell and zoom it out. Let's take, for example, I am taking this tumor cell. And if I can zoom it out, any of the tumor cell, and describe the tumor cell. Now here, all these tumor cells have nucleus. All these tumor cells have nucleus inside them. So 3 features of the nucleus are very important. I'm drawing a nucleus here. Nucleus. So 3 features of the nucleus are ultra important. Nucleus is having certain 3 very important features. Let me tell you that. So first thing we have seen, there is papillary pattern. The tumor cells are arranged in the papillae with a fibrovascular stalk or fibrovascular core inside them. Appreciate the papillae here and appreciate the fibrovascular stalk, the fibrovascular core here. Can you see this is fibrovascular core? This is all about fibrovascular core. Okay, and these are the tumor cells which are lining the papillae. These are the tumor cells which are lining the papillae. Okay, now tumor cells. Describe one tumor cell. See the nucleus of that. On the next page, I will zoom it out. Can you see we are zooming the tumor cells? So can you see this is all the papillae. The tumor cells are arranged in papillae. Now see any one of the cell. Can you see the nucleus? Highlight the nucleus. The nucleus is optically clear. Now see, this is a cell. This is a cell. Here I am drawing the nucleus and here I am drawing the nucleus. Got it? So here this type of nucleus is known as hyperchromatic nucleus. Hyperchromatic nucleus. It's very compact, darkly stained, and this nucleus is empty from inside. It's known as optically clear nucleus. Optically clear nucleus. So here in papillary carcinoma of thyroid, we have this nucleus. We don't have this one. So optically clear nucleus is there. So can you see the nucleus? Now appreciate. All the nucleus are clear from inside. They are optically clear. They are not filled. They are not colored. They are optically clear. They are also known as ground glass nucleus. So either call optically clear, the nucleus are optically clear, or you call them ground glass. The nucleus are looking like ground glass. Do you know a cartoon character known as Annie? Annie is a cartoon character like the McDonald, like many Donald Duck. You know, there are many cartoon characters are there. Mickey Mouse. So Annie is a cartoon character. She is orphan. Orphan Annie. She's a girl. She's Orphan Annie. So in this cartoon character, the eyes are shown empty like this. If you have seen the cartoons of Annie, you may have seen the eyes are empty. So can I compare the nucleus with the eyes of the Annie? Yes, it is known as Orphan Annie Eye nucleus. The appearance of the nucleus is known as orphan because it is optically clear. It's empty from inside. So the nucleus of the tumor cell is looking like the eyes of the Orphan Annie because the eyes of the Orphan Annie are empty from inside and the nucleus is also empty from inside. It's optically clear, ground glass, also known as Orphan Annie Eye. Orphan Annie Eye nucleus. So that is the first thing inside the nucleus. The nucleus is optically clear. It is Orphan Annie Eye nucleus, also known as ground glass appearance. So that is the first thing in the nucleus we have seen. Now inside the nucleus, two more things are there. So let me draw a tumor cell for you. This is one of the tumor cell. Let me draw the nucleus of the tumor cell. It's optically clear. It's optically clear, ground glass, Orphan Annie Eye. Now inside this, two things can be present. Number one, grooving. It is looking like a groove. Have you seen a coffee bean? It's looking like a groove. So most of the nucleus may have the groove. Not all, but most of them can have a groove. And some of them, let me draw one more tumor cell. Let me draw one more nucleus. Some of them may have an inclusion body also. Pseudo inclusion body. So inside the nucleus, which is clear, optically clear, grooving can be there. This is known as groove inside the nucleus. And the inclusion bodies can be there. So inclusion bodies can be there. So the nucleus have three common features, three important features. So this is a tumor cell. This is the nucleus. Number one, I will write the nucleus is Orphan Annie Eye. Orphan Annie Eye nucleus. That means the nucleus is optically clear. That means it is ground glass appearance. Inside the nucleus, I will draw a groove and I will label it. This is nuclear grooving. Grooves are very common and inside the nucleus inclusions may be present. So this is known as inclusions. Nuclear inclusions or pseudo inclusions are present. So these are the three important features of the nucleus of a papillary carcinoma. So try to see it here also. So here you can see the nucleus is optically clear, but let me zoom it further. Let me magnify it further. So now you can see the magnification and here in the magnification you can see this is the grooving. Appreciate the grooving, appreciate the grooving, appreciate the grooving, appreciate the grooving, appreciate the grooving. Can you see this is all grooving? This is all grooving. Can you see this is all grooving? Now you at some places here also you can appreciate. So in the nucleus is optically clear. Inside some of them you can see the inclusion bodies. Appreciate the grooving here. Appreciate here it is light inclusion body. So in some of them inclusion bodies is there. So that is grooving is common and inclusions are common. And the last thing, sometimes Psammoma bodies are present. What is Psammoma body? Psammoma body is calcification in the tumor. So sometimes the calcium get deposited in the form of the concentric rings, laminated rings. This is calcium. What is it? It is calcium. Calcium get deposited in the form of the concentric laminated ring. It is known as Psammoma body. So can you see this is a Psammoma body? It is the blue color concentric rings. This is the Psammoma body. So small concentric laminated calcification spirules are common. So that's all about the papillary carcinoma. So if I want to draw a diagram of papillary carcinoma in my university exam, I will draw a box. I will try to draw the tumor cells on this. How I will draw the tumor cells? I will draw few papillae and I will show the arrangement is papillary. The arrangement is the papillary. I will show that. And inside the papillae, I will draw the core. The core is fibrovascular. So these are the blood vessels, and over which a little bit of fibrosis is present. We can draw few fibers. A little bit of fibrosis is present in the core. So fibrovascular cores are common. So this is the thing. The first thing is arrangement. Now I will draw the tumor cells. So I'm drawing the tumor cells over here. These are the tumor cells. So the tumor cells are arranged over there. Now inside the tumor cells, we have the nucleus of the tumor cell, which is optically clear. It is optically clear, Orphan Annie Eye, ground glass appearance. And inside some nucleus, I will draw the grooving. Not all, but in some of them, I will draw the grooving. And in some of the nucleus, I will draw the inclusion bodies. And I will label all these things. So I will label the nucleus is optically clear. It is having the grooving. It is having the inclusion body. This is papillary arrangement. This is fibrovascular stalk. And at some places, I will draw the concentric rings inside the tumor. The concentric rings, the laminated rings, the blue color, purple color concentric rings. And I will label it as Psammoma body. So this is all about it. All about it. See the arrangement, see the tumor cell peculiarity, and see the unique feature Psammoma body. That's all about it. This is the microscopy you have to draw like this. Now coming on the spread. The spread is lymphatic spread. Papillary carcinoma spread mostly by lymphatic route, and prognosis is excellent. The 5-year survival is up to 90%, 80 to 90, 95%. It is the least malignant thyroid tumor among the 4. It's have very good prognosis. So we are done with the first one, the papillary carcinoma. Can we revise quickly? We have to go 3 more. So can we revise it quickly? Yes, among the 4 in the introduction, write down this is the most common. It constitutes 70%, 75% of the total. Cell of origin, it arises from follicular cell. Age, it occurs in young female 20 to 40 years. Female to male ratio, it's 3:1, more common in female. Risk factor is radiation exposure. Genetics, genetic alteration, the mutation, it is the RET gene and anti-RK gene. And in the gross, the tumor is well circumscribed, encapsulated, having the papillary projection grayish white. Microscopy I have discussed. So you have to tell the arrangement of the tumor cells, fibrovascular stalk, the nucleus of the tumor cells, and Psammoma bodies. Spread, you have to say it's lymphatic spread. And prognosis is excellent. The 5-year survival is 80 to 95%. Among the 4, this is the least malignant one. So we are done. We are done with the first one. Now coming on the second, follicular carcinoma. Let's start the follicular carcinoma under these headings only. Follicular carcinoma of thyroid. This is the second most common type of thyroid tumor. So papillary was constituting 70% of the total. This one is constituting 10 to 20%. So it is the second most common. This was the most common. This is second most common. It constitutes 10 to 20% of the total. So second most common. Cell of origin is follicular only. So except medullary, the remaining 3 are arising from the follicular origin. Age is little bit middle-aged female, 40 to 50 years. This was there in 20 to 40. This is 40 to 50 years. 40 to 50 years. Compared. Male to female ratio is, again, it is more common in female as compared to male. So it is 2.5 times more common in female as compared to male. So ratio is 2.5:1. It's female is to male. Here also it is more common in female. Here also it is more common in female. But you have to learn the ratio also. Risk factor is iodine deficiency. Here the risk factor was radiation exposure. Here it's iodine deficiency, leading to endemic goiter, multinodular goiter. Genes, most commonly RAS gene is mutated and PAX-PPAR. RAS and PAX-PPAR. Here RET and anti-RK. Here RAS and PPAR, PAX-PPAR, RAS and PAX-PPAR. These are the 2 genes which are mutated. Now coming on the gross and microscopy. So look at the gross. This is the tumor. See the borders of the tumor. Can you appreciate the borders of the tumor? Appreciate the borders. So tumor is large. It's looking very large, and it penetrates the capsule at multiple places and come outside. It is having a capsule, but it penetrates the capsule and infiltrate inside the capsule. That is the unique feature. That is a unique feature that differentiates follicular adenoma from follicular carcinoma. Currently, I am teaching you carcinoma. Adenoma is the benign tumor, but follicular adenoma and carcinoma is differentiated based on the capsular invasion. So capsular invasion is present in carcinoma but absent in adenoma. Otherwise, microscopically, both of them look same. Now coming on the microscopy. In the microscopy, again, you tell me the same thing. Tell me the arrangement of the tumor cells. How the tumor cells are arranged. So here the tumor cells are arranged in follicular pattern, not in papillary pattern. What you can see, all the tumor cells are arranged in small follicular pattern. These all are tumor cells, and small cuboidal cells are lining the follicles. So small cuboidal cells. So this is a follicle. It is lined by the tumor cells, the cuboidal cells, the tumor cells. Now the nucleus of these cells is hyperchromatic. If you can zoom and see, the nucleus is very dark. In contrast to papillary carcinoma, where the nucleus was optically clear, here the nucleus is hyperchromatic. The nucleus is hyperchromatic. That is the thing. Now, so you have to draw like this. So make a box. Can you draw the tumor cells, the follicular carcinoma? So they are in the form of the follicles. The tumor cells are in the form of the follicles. These are the tumor cells lining the follicles. The nucleus is dark, hyperchromatic. It's not optically clear. It's not ground glass. It's not Orphan Annie Eye. It's hyperchromatic. It's like this. So till now we have learned this. Now two important features you have to learn. Let me explain. Can you see the capsule in this diagram? Look at the diagram. Can you make out where is the capsule? Let me highlight the capsule for you. Now in this diagram, can you see these pink fibers? Have a look. The pink fibers, this is capsule. Can you see these pink fibers? This is the capsule. Okay, this is the capsule. Can you see it is infiltrated by the tumor cell? The tumor cells are penetrating through and through the capsule. So very well it is shown in the diagram that here is a capsule and it is infiltrated by the tumor cell. So you all can see these all are the tumor cells which are infiltrating and going through and through to the capsule. So vascular invasion is very common. Capsular invasion, direct invasion or capsular invasion is common. Number one. So you have to draw a capsule in your exam. So how to draw a capsule? You have to draw the pink color fibers. Label it a capsule. Label it as capsule and please try to draw the tumor cells infiltrating the capsule. So capsular invasion is very common. You can appreciate it as infiltrating. Number one. Number two, draw a blood vessel. Can you see a blood vessel in this diagram? Yes. You can see here is the blood vessel. If you can see, this is the blood vessel. Okay, blood vessel contains the blood. You can see the red colored blood inside that. But what you can see apart from the blood? What are these cells? Oh my God, the tumor cells infiltrated inside the blood vessel. So draw a blood vessel and try to draw few tumor cells inside the blood vessel. It is known as vascular invasion. So capsular and vascular both invasion are seen. So I can see the capsule. This is the capsule and I can see the tumor is infiltrating through the capsule and I can see a blood vessel and I can see the tumor is going inside the blood vessel. So two invasion, capsular invasion and vascular invasion. Vascular and capsular invasion both are very common in follicular carcinoma. That you have to learn. So what we have learned, how I will draw it. So I will draw like this. So I will draw a box. I will draw the tumor cells are arranged in small follicles. These all are follicles. The tumor cells lining the follicles like this. The nucleus of the tumor cells is hyperchromatic. It's not optically clear. Then I will draw a capsule. I will try to draw a capsule with pinkish fibers like this. And I will infiltrate the capsule with the tumor cell. So between the capsule, I will try to draw the follicles and the tumor cells infiltrating it. So I will label it as capsular invasion. Then I will draw a blood vessel. It contains the blood inside that. You can see this is all blood. And then I will infiltrate it with the tumor cell. I will try to draw few tumor cells and I will label it as vascular invasion. So capsular invasion is common, vascular invasion is common, the arrangement is follicular, you have to say that. Now there is a variant of follicular carcinoma known as Hürthle cell carcinoma. So Hürthle cell carcinoma is the variant of follicular. So sometimes you get a very short note on Hürthle cell. So you must understand what is Hürthle cell. The first thing you have to write, it's a variant of follicular carcinoma. So here, what is the difference? Here the tumor cells are arranged in follicles only, but tumor cells are different. What is the difference? You can see the tumor cells are very big, they are large, having abundant of pink eosinophilic granular cytoplasm. Can you see the cytoplasm? This is the cell, this is the nucleus of the cell. See the cytoplasm. Say ma'am, the cytoplasm is pink, eosinophilic and granular. You can appreciate the granularity in the cytoplasm. So cytoplasm is very pink, very acidophilic, that is eosinophilic, that is granular, and abundantly granular because it is filled with mitochondria. It's a very aggressive type of tumor. It is the aggressive variant of the follicular carcinoma. Here more than 50% of cells are Hürthle cells. These cells are known as Hürthle cell. So instead of this, we can get sometime this variant. So that is Hürthle cell carcinoma. What is the spread? Follicular carcinoma mainly spread by blood route to the bone, lungs and liver, in contrast to papillary carcinoma, which was mainly spreading by the lymphatic route. Prognosis is good here. So 10-year survival is up to 70%. It is not as good as papillary, but relatively good. So we are done with 2. So till now we are done with 2. So let's revise follicular quickly. In the end, we will revise all 4 together. So here this is, papillary was most common. This is second most common. Papillary constitute 70% of the total. This constitute 10 to 20% of the total. Cell of origin here also follicular, here also follicular. Age, it is common in 20 to 40. It is common in 40 to 50. Female to male ratio, if you see female to male, this is 3:1, this is 2.5:1, so hardly makes any difference. Ultimately, both are common in female as compared to male. If you see the risk factor here, radiation exposure, and here iodine deficiency. If you say the mutation, here most important RET, mutation and NTRK. Here most important are RAS and PPRX. That is the mutations. Now gross you can write down by your own, not important, but microscopically you have to draw the diagram. So here you have to draw in papillary projections. The tumor cells are arranged in papillary with fibrovascular stalk. Here the tumor cells are arranged in follicular pattern. So here the other important thing is the tumor cell optically clear nucleus, grooving, inclusion bodies, and Psammoma bodies. And here it is capsular invasion, vascular invasion, and a variant of it is Hürthle cell. Lymphatic spread, if you see for both of them, here it is more common lymphatic spread, and here the more common route of spread is hematogenous. Prognosis wise, if you see, the papillary carcinoma is having 10 years survival up to 85%, 95%, and this one up to 70%. So both of them have good prognosis, but overall papillary have a more good prognosis as compared to follicular. Coming on the third one, medullary. This is how you have to learn, and it will retain in your memory permanently. Coming on the third carcinoma, that is medullary thyroid carcinoma. So can I start the third one? Yes. So let's start medullary thyroid carcinoma. It is the third most common. Most common is papillary, second most common is follicular, the third most common is medullary. It constitutes 5% of the total. Papillary constitutes 70%, follicular constitute 10 to 20%, and medullary is constituting 5% of the total tumors of the thyroid. Cell of origin is parafollicular. It's very, very unique thing. All other 3 tumors, that is papillary, follicular, and anaplastic, they arise from the follicular cell. But this one, that is medullary, it is arising from parafollicular cell. So since it is arising from parafollicular cell, it secretes calcitonin in the blood. So that is something unique for the medullary carcinoma of thyroid. So if we are suspecting medullary carcinoma in any patient of thyroid, so we will check the blood levels. In the blood, if we are getting calcitonin at higher side, so your diagnosis will be supported for this. Age group is 40 to 50 years. But the unique thing, it is same in male and female. Till now, I taught you 2 other tumors, that is papillary and follicular. In both of them, I told you they are common in female as compared to male. First time I'm telling you in medullary, it is same. The incidence is same in male and female. So ratio is 1:1. So that is something unique. You get MCQs on that. What is the risk factor? It is associated with man. It is associated with man syndrome. There is a separate video of mine on man. So I request you to watch that video also. You will understand in man 2A and man 2B, medullary carcinoma of thyroid is a component of the man syndrome. So risk factor is the man syndrome. And genetic alteration, it is the RET gene, which is mutated. The name of the gene is RET. Now coming on the gross, the tumor is gray, pale, firm, abundant areas of hemorrhage and necrosis are there. Abundant, extensive areas of hemorrhage and necrosis is there. That is the tumor. Gross is not very important, frankly. Coming on the microscopy. Very unique microscopy. Can you see the tumor cells are arranged in small nesting pattern? This is a nest. 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 You can see the tumor cells are arranged in small nesting pattern. First say the arrangement. So arrangement is not papillary. The arrangement is not follicular. It's small clusters. That is known as nesting pattern. And they are separated from each other by fibrovascular septa. All the nests are separated from each other. I have drawn the blue color. These are the fibrovascular septa. Now, all the tumor cells are uniform. They don't show pleomorphism. They are very same looking. Can you see the tumor cells? They all are same looking. Same looking. They are very uniform. They are very uniform. Now, the background is very important. Can you appreciate the background here? Let me highlight the background. Can you see something pink color deposit in the background? Pinkish background. So this is eosinophilic acellular pinkish background. Eosinophilic acellular pinkish background is there. So what is this thing? It is known as amyloid. So amyloid stroma. That is amyloid stroma. That is something unique in medullary carcinoma of thyroid. And calcifications are very frequent. So can you see this is the calcification, the bluish deposit. This is the calcification. The calcification is not in the form of the concentric rings. No, no, no. I will say calcification. I am not calling it Psammoma body. So calcification was common in papillary carcinoma also. But there the calcification was in concentric rings. So I called their Psammoma body. Here I am simply calling calcification. I am not saying it's Psammoma body. That is the microscopy. Now the spread here is lymphatic also, blood also. In papillary, only lymphatic, mostly lymphatic. In follicular, mostly blood. Here it is both. Prognosis is good. The 10-year survival is 60 to 70%. So it is relatively good. The last one is anaplastic. We will see the anaplastic and compare all four together. The last one is anaplastic. It constitutes less than 5%. It is the least common among the four. It is the least common thyroid malignancy, but it is most malignant, but it is most aggressive. It is rapidly growing. Among the four, this is worst prognosis. Among the four, it is most aggressive. Among the four, it is the most malignant one. Cell of origin is follicular only. It occurs in old age, 70 to 80 years. 70 to 80 years, very old age. Again, it is more common in female. Female as compared to male. And the ratio is 1.5:1. If you see the genes which is mutated, it is P53 or beta-catenin. P53 mutation and beta-catenin mutation. Grossly, it's a very infiltrative tumor. You can see it is infiltrating everywhere with high areas of hemorrhage and necrosis. Microscopically, it's very poorly differentiated. There is no fixed microscopy. 3 different patterns are observed. You don't have to draw it. You just learn it. 3 different patterns are there. Sometimes it is looking like squamous. It is looking like squamoid. Can you see squamoid pattern? Sometimes it is looking like spindle cells. Can you see all the tumor cells are looking spindeloid? They are looking like spindle cells. All the tumor cells are looking spindly. So it is spindeloid pattern, spindle, and sometimes it is giant cells. So most of the tumor cells are giant cells. Can you see here? Most of the tumor cells are giant cells having multiple nucleus. So either the tumor cells are polygonal, big polygonal containing keratin in them, it's known as squamous pattern. Or the tumor cells are spindle shaped. This one is known as spindle pattern. Or the tumor cells have multiple nucleus inside them. This is known as giant cell. So 3 patterns are there. In some patient it is like this, in some patient it is like this, and some patient it is like this. So anaplastic don't have any fixed pattern. It's the worst, it's most aggressive, it's most malignant, having poor prognosis. So that is anaplastic. The spread, mostly the spread is local. It keep on infiltrating in the adjacent organ. So it is there in the thyroid. Now from the thyroid, it will go in the trachea, it will go in the airway, it will go in the esophagus. It will spread everywhere locally. So it will spread in the adjacent neck organs, and that's why it's very destructive. And via blood, it can spread to the lungs also. Prognosis is worse. 10-year survival is only 5 to 10%. So out of the 100 patients, only 5 to 10 will survive after 10 years. The remaining 90 will die because it is very aggressive. It is almost 100% mortality. If treatment is not given, in just 2 months, patient die. 100% mortality if treatment is not given. If treatment given, even after the treatment, after 10 years, only 10% will survive. It's very aggressive. That is anaplastic. So we are done with the 4 types. So can we compare the 4 quickly? The 4 types of the thyroid tumor. So introduction, this is the most common type, this is the second most common type, this is the third most common type, this is the least type. You know percentage wise also. Now cell of origin, this is follicular, this is follicular, this is parafollicular, and this one follicular. So since medullary is parafollicular, it secretes calcitonin in the blood. If you see the age group, so this occurs in young female 20 to 40, this one occurs 40 to 60, this one also occurs 40 to 60, this one occurs 60 to 80, old age. So see, this one is in young, this one is in old, and these 2 are in middle to old female. So you have to learn this. Now female to male ratio is something very important. So here it's 3:1, more common in female. 2.5:1, more common in female. Here it is 1:1. Only medullary is same in male and female. And here also it's 1.5:1. So only medullary is something unique which is same in male and female. Rest all are more common in female. That is a very important MCQ. Coming on the risk factor. Here only one risk factor, radiation exposure. In papillary. In follicular, it's iodine deficiency. Iodine is deficient. In medullary, the risk factor is Man syndrome. Man 2A and Man 2B. And in anaplastic, there is no risk factor. Okay, now coming on the genetic mutations. Can you enumerate the genes which are mutated? In papillary, it's RET gene and NTRK gene which is mutated. In follicular, it's RAS and PPAR gene which is mutated. In medullary, again it's RET gene which is mutated in Man 2A, Man 2B. And in anaplastic, either it's P53 or beta-catenin pathway. So you have to learn that. Now coming on the gross and microscopy of each of them, the most important thing. So let me come on the gross and microscopy of each of them, the 4. So gross is frankly not very important. You can skip most of them, but microscopy is something you don't have to write, but you have to draw it. So let me draw the microscopy of the 4 for you. So let's come on the microscopy directly. Okay, so let me show you the microscopy of the 4. So papillary, here, tell me the arrangement. Here the arrangement, the tumor cells are arranged in papilla with a fibrovascular stalk at the center. Here the tumor cells are arranged in follicles. Here the tumor cells are arranged in nesting pattern, and here 3 patterns are observed: squamoid pattern, spindle shaped pattern, and giant cell pattern. First, you have to tell the arrangement. Now after arrangement, tell me the morphology of the tumor cell. Here tumor cell nucleus is important. Nucleus is optically clear, known as Orphan Annie Eye nucleus, ground glass appearance nucleus. It is having the grooves and inclusions along with Psammoma bodies. Psammoma bodies. Here unique feature is that vascular invasion and capsular invasion is there. The tumor cells are invading the vessels and the capsule. You have to show it in the diagram. And one of the variant is Hürthle cell. You have to describe and draw that also. Here, the background is important. The background contains the pinkish material, that is amyloid. Pinkish acellular material, that is amyloid. You have to draw it in the diagram. And calcification is common, but it's not Psammoma like this, but calcification is common. And here nothing is important. So that's how you have to draw the microscopy of all 4 together. You can see it. You can see papillary, you have to draw like this. Follicular, you have to draw like this. Medullary, you have to draw like this. See the arrangement. Here it is papilla, here it is follicular, and here it is nesting. And here 3 different patterns are observed. Now learn the unique features of all of them. That's all about it. So after that, spread, if you talk about the spread of each of them. So I told you the spread and the prognosis also. So if you talk about the spread, in papillary, the spread is lymphatic. In follicular, it is blood, hematogenous. Here it is both lymphatic plus blood. And here mostly it is direct to the adjacent organ. That's why the prognosis is worse. And it is hematogenous also. If you see the prognosis, 10 years survival, here is 95%, here 70%, here 70%, here only 5 to 10%. This one is the worst and this one is the best. So that's all about it. Same table is filled in front of you. You can read it. You can see all about it. So if any one of them is asked in your exam, you have to write that only. And if particular feature of that particular carcinoma is asked, write that only. Don't forget to look at the long, short, very short question and MCQs of this topic given in the notes and question bank. Thank you.